Hi, everyone. I'm Anne-Marie Kovacs, Head of Strategy here at Fluo Labs, and really happy and excited that this is our first online Q&A. And I'm here with my colleagues, Gabby DiMarino, and you might recognize her as our community manager, and Marina Christos, who helps run all the magic behind the scenes. And they'll be pushing all the buttons and pulling all the levers. So if you hear me calling for help, you'll know who I am referring to. Also our guest, Dr. Edward Lisberg, and I will formally introduce him in just a moment. So again, welcome to our Q&A session. We have 45 minutes with Dr. Lisberg. And we'll get straight to your questions about allergy medications, and probably basic things like that, what the label won't tell you about the medication, or things you always wanted to know. So this is not going to be a webinar or a presentation per se, in the sense that we don't have slides. Instead, we wanted to offer something that would be actually useful, have some good takeaways, maybe even actionable based on questions that you have asked us. So we're probably going to have a few more people coming in the next couple of minutes, and as we're waiting for those last few people, I wanted to just go through the housekeeping really fast. Just getting that out of the way. So by registering to be here, you've already agreed to our terms and conditions. And to recap, this is a free session offered for informational purposes only, and should not by any means replace the medical advice that you would receive from your own professional medical expert or doctor. Dr. Lisberg would also not be answering any personal medical questions or offering any personal advice. You have to go see your own doctor for that. And we are recording the session. So if you're here, that means that you're okay with that. And if you're not okay with not comfortable with the camera, just turn that off. All right. If you have any questions, additional besides the ones you might have already sent in, you can go ahead and do we want to put up the question box, Marina? Or yeah. Okay. If you have any other questions, feel free to type them in. We'll try to get to as many questions as we can. We've preloaded some of the questions that you have already asked, and you can upvote the questions that you feel you might most want the answer to. So again, we'll try to get through as many as we can today. We are going to mute the guests. Don't take it personally. It's really so that we can be as efficient as possible and move through as many of those questions. I will be asking the questions on your behalf. And if we have any extra time at the end, or if you have any follow-up questions, just raise the hand icon and we'll try to get to you. So about Dr. Lisberg, he is a board-certified allergist and immunologist with over 30 years of experience as a physical specialist in the areas of allergy, asthma, and COPD clinical care. He is a certified principal investigator and has investigated over 160 clinical trials in allergy, asthma, and related diseases. And he's a fellow of the American College of Chest Physicians and the former director of the Asthma and Allergy Center of Chicago in Illinois. So he kind of knows what he's talking about. And he is currently developing Abitas, which is a respiratory medical device. Our company has worked with Dr. Lisberg a few years ago, and he helped us conduct our first pivotal trial for our technology. We need to mention that today and make sure that everybody knows he's not compensated for being here. He's here because we really appreciate his no-nonsense approach. We might owe him a drink after this. So to get started, where are these questions? Marina?
They're in the Q&A.
They're in the Q&A. Okay, why?
Do you want,
No,
yeah.
I will find it. Okay.
Did you find the Q&A?
I got it. I got it.
Okay,
Good.
all right, awesome.
All right. I'm not seeing any upvotes, so I'm just going to go with the first one I see up here is, and medications that were reliable suddenly stop working. Ed.
Thank you. Big general question. So typically when we hear that, it's in relation to people saying, gee, I was taking an antihistamine and it seemed to work for the first couple of days and now it doesn't seem to work anymore. And it probably relates to specifically the antihistamines that when you're exposed to something you're allergic to, histamines release and it kind of peaks within about 3 to 5 days or so and then goes down after about 7 to 10 days. There's not a lot of histamine release, and therefore people oftentimes will take an antihistamine and say, gee, it worked for a week, and after a week it just doesn't seem to help anymore. It doesn't help because the histamine itself really isn't the ongoing, the cause of ongoing symptoms after about 7 to 10 days. You know, if you get repeated exposure again, you may get a burst of histamine, but again, that's why antihistamines tend to be fairly poor drugs used chronically to treat allergies. So
What happens after those?
What?
I'm sorry, I don't know if everybody else is getting the echo. What happens after those 10 days?
Well, after the 7 to 10, it just goes to the fact that antihistamines are, you know, effective drugs if you're exposed acutely to something, but if you have ongoing allergy symptoms, antihistamines really play a minor role in terms of providing symptom relief for people who have symptoms that last for more than 7 to 10 days.
Okay. Is this preventing the echo? Yeah? Okay.
Yeah.
So
I can barely hear you.
You can barely hear me. Okay, this way?
That's better.
Okay. All right. So then that might kind of go into the other question that we had here about how are antihistamines different than corticosteroids, and when should you know which to use, or does one complement the other?
So, you know, if all allergies were related just to one chemical that your body produces, you know, one drug or one medication would effectively control it. And it goes to the fact of the matter that, right, allergies, you know, basically antihistamines play a role in terms of acute exposure, but for people who have seasonal symptoms or year-round symptoms, antihistamines tend to be very poor drugs. Then nasal corticosteroids and medications like that, basically, you don't develop tolerance to, they continue to work. And if you have symptoms that last for more than 14 days, even on a cost basis, it's much more cost effective to be using a nasal steroid than an antihistamine. Using the two of them together may provide some benefits to people, and it's conflicting in terms of the information that's been produced, because most of the information is in marketing studies, you know, after these drugs are already out, so that they all tend to kind of indicate different things. But the combination of an antihistamine plus a nasal steroid tends to work better than just the nasal steroid alone for a lot of people. But again, the limiting factor tends to be side effects for most of these drugs.
So you touched on the marketing aspects. Why do you think that some of these companies are presenting it a certain way that might not be as helpful to the patient as could be?
I guess pharmaceutical companies produce products that they want people to buy, and by the way, they affect people's health. So I can't really speak for the pharmaceutical industry, but they're for-profit businesses that want to sell things. So
right,
they're going to produce whatever will support that type of marketing and sales activity. Obviously, I don't think they intentionally produce things that are misleading, but they certainly parse the information.
All right, so I guess that would be part of the source of the confusion that allergy sufferers have, that we're not getting the full picture as consumers.
Well, part of the confusion also is that the general medical community has very little understanding of allergies to start with. So most physicians, primary care physicians, have very little training in allergy, and they just tend to prescribe medications, but don't tend to prescribe therapy that is, matches the characteristics of the person that's in front of them. So they tend to just go medication and medication and medication, and not really understanding in terms of the primacy or secondary nature, or really how to approach patients with allergic disease.
So really, it's kind of like the elimination diet, but done with the medication.
Well, I mean, the general attitude we see in the community is that basically it's a physicians say, well, look, this is something that's not life-threatening. You know, I'll try this, I'll try this, I'll try this. So when I see patients, they've been tried on a variety of different medications. It don't make a lot of medical sense, but basically it's physicians, you know, will just prescribe and prescribe and prescribe, and then go, nothing seems to be working. Maybe I should send them to a specialist.
Okay. All right. My last question here. So if allergies are not getting worse, it seems that people are diagnosed or self-diagnosing more and more with allergies, seasonal allergies. Do you think there is more talk in your industry? Have you seen, over your 30 years of experience, have you seen more attention being paid to allergies?
Attention by whom?
By doctors, by the medical community.
Well, I mean, I think the medical communities, their attention is focused on in terms of what they have to offer patients, which is basically things based from the pharmaceutical industry. So if the pharmaceutical industry pays attention to things, their focus is in terms of marketing it out to doctors. You know, I'm not sure that we're seeing necessarily more allergic disease, but when new products come out or new therapies come out, there's certainly much more focus in the community about that, because they're new products to sell. And I think, you know, physicians want to do things that are in the best interest of their patients. You know, I don't think that anyone intentionally just gives somebody therapy, you know, because they've been marketed that way. But, you know, I think that, you know, the term allergies, it's a cultural term more than a medical term in our society. So, I mean, if you're sitting next to somebody on the bus and they sneeze, immediately you turn and go, oh, allergies. You know, if someone eats something and that doesn't feel good, you go, oh, allergies. So it's something that's culturally there. And, you know, with the internet, certainly it's much more widely used in terms of a cultural term than an actual medical term. And 2/3 of the people out there, you know, when surveyed, say that they have some sort of allergy, when we know that that's just, you know, way exaggerating the actual instance of allergy in the population.
So most people don't have straight allergies.
Well, I mean, the term allergy, I mean, there are all different types of allergies. So yes, people truly do have allergies. The question in terms of just differentiating people who have allergies from non-allergic disease causing similar symptoms, and that's where, you know, the proper diagnosis and, you know, comes in.
Okay, and see your doctor for that, right? All right. So one question. You know, one of the symptoms of allergies is brain fog, fatigue. And one of the questions we have here is it the antihistamines or the allergies themselves that are causing the fatigue?
So it's kind of interesting. You know, the main reason I would tell, you know, doctors training with me, people come to you not because they're itching or sneezing. Yeah, that's a problem. But they come to you because they feel bad. And why do they feel bad? They feel bad because allergies themselves cause disruption of sleep cycle. So if you do sleep cycle monitoring people with allergies, even with treated allergies, they're not appropriately treated, that basically they have poor sleep cycles and therefore they just feel lousy during the day. Now, the problem with, you know, antihistamines, certainly the traditional antihistamines or sedating antihistamines, is they can also cause a further disruption of the sleep cycle. I'll see that, you know, some providers will tell patients, well, take Benadryl at bedtime because it'll knock you out anyway. Well, you have a disease process which knocks you out, which causes brain fog, and now you're taking medication that causes more brain fog. So people wake up cognitively impaired in the morning. Okay, because they've taken something that's further disrupt their sleep cycle. So from my perspective, I mean, unless there's a specific indication, you should never be prescribing antihistamines that cause sedation or somnolence for people. All antihistamines do the same thing. The differences are their side effect. So that it makes no sense if you have a disease process that causes sedation or drowsiness or cognitive impairment that you prescribe a medication that also has that side effect.
So it would be the sleep, lack of sleep or poor sleep would be the main culprit in the brain fog, as opposed to having mucus or feeling all of this gunk in your head.
So it's part of the, you know, overall general inflammatory process involved in allergies, and certain mediators are released that cause an alteration in the sleep cycle and impair your sleep cycle. It's not because your nose is stuffy, right?
It's not because your nose is stuffy. That's interesting. Okay. Because That's what I always thought when I had a cold, let's say. Okay, definitely. All right, okay. We might have some follow-up questions on all of this. That's great, guys. If you want to go and add all of this into the questions, the question tab, ask the question little button. We have a few questions about immunotherapy. It's seen as a natural option, but can immunotherapy cause side effects?
So immunotherapy or allergy vaccine therapy or allergy vaccine immunotherapy, it's the only kind of basically preventive therapy we have out there. The problem is how it's applied in the real world, that oftentimes the therapy itself is termed to be ineffective in some people just because they aren't on the proper dosing and regimen of immunotherapy. Traditionally called allergy shots. Now there's also oral, immunotherapy, pills or drops under the tongue, but there are very few FDA-approved medications for that. Part of the problem in the community, we see frequently some doctors advertising that they do sublingual drops for allergy, immunotherapy, and they use FDA-approved extracts. The extracts are approved not for oral or sublingual immunotherapy themselves and for the treatment. And I've always questioned why a physician would advocate that people take a non-FDA-approved treatment for their disease. The risks and long-term benefits are just unknown from sublingual therapy. But allergy immunotherapy, there's a build-up phase, and they're called to get to what's called maintenance, which is the highest tolerable dose of the specific allergen that causes your symptoms, not necessarily to what you have a positive test to only. So that basically it's to what you have symptoms to. And once you reach maintenance, there's a year of consecutive therapy on maintenance. If there's no clear defined benefit, and clear defined benefit is, oh yes, I'm clearly better, not, oh, I'm not sure, or I think it's helping. It's like, it's clearly defined that you're better. So that basically after a year, if there's no clear defined benefit from the therapy, there's no actually indication to continue therapy, because if there's no clear defined benefit after 1 year of maintenance, going on to a second year of maintenance will not provide any more benefit. For those people who do achieve some benefit, clear defined benefit, then continuing therapy for a maximum of 3 to 5 years. Beyond that, there's no data to indicate that continuing allergy shots after 3 to 5 years of maintenance therapy provides any further protective benefit for people. The key is also with allergy medications. If you're given the medication, whether it's a nose spray or a pill for allergies, you should see a clear defined benefit within 7 days of starting the therapy. If you don't see a clear defined benefit, you need to speak to your doctor about your diagnosis or your treatment plan. So that the whole idea in terms of treatment here is that we're seeing clear defined improvement in patient's symptoms, not, oh, I think I'm better, or I'm not sure, or maybe helping me.
Okay, clear defined benefits. So for antihistamines or corticosteroids, you say it's about 7 days. It's about a year for immunotherapy.
No, so basically, immunotherapy, you're put on an increasing dose schedule to get what's called maintenance, which is a fixed highest dose that you can tolerate. Once you're on maintenance therapy, after a year on maintenance therapy, you should be reevaluated. And at that time, there should also be yes, I am clearly better on this therapy than when before I started therapy. For those people who don't have that clear defined benefit after a year, allergy shot therapy should be stopped.
Okay, understood. And what is the usual period you need to get to that maintenance?
Well,
level?
It depends. There are all different ways of giving immunotherapy. So you can do what's called a rush schedule, where basically you can get up to maintenance within 2 days, or 1 day, or 3 days. Okay, there are modified rush schedules, which you take after a week, or 2 weeks, or a month. Or there's the standard traditional schedules, which take about 3 months to get up to maintenance.
Okay,
so there are all different ways of administering immunotherapy, and that's why it should only be done by somebody who's actually trained and understands the process.
Okay, right. But back to the original question is, does it have side effects besides potential efficacy? Are there any side effects that people don't talk about?
So short-term side effects, basically, discomfort at the site of injection.
One thing
from people. there's always a risk, no matter how long you've been on allergen immunotherapy, of experiencing systemic side effects, potentially life-threatening, even anaphylaxis, although it's rare, but it can occur. Some people may see a temporary worsening of their symptoms on the day that their immunotherapy is administered or subsequent days. All those things can be ameliorated or lessened by the use of certain medications, which can be prescribed by the treating physician.
Okay. Fun stuff like having the side effects from the COVID vaccine. Okay.
But obviously, hopefully the benefits outweigh the side effects for people.
Exactly. All right. Follow-up question to that is, can immunotherapy stop working after a few years?
So does it stop working? So as I said, after, continuing immunotherapy for the majority of patients, 3 years is sufficient therapy. Some people out to 5 years, but certainly beyond that, continue to take allergy shots is of no documented benefit in terms of providing more protective effect. So if someone says, gee, it worked the first year and didn't work the second or third year, unless there's been a dramatic change in their environment, it raises the question in terms of whether the immunotherapy actually provided the perceived benefit that first year. But once the therapy, if there's no more perceived benefit from any therapy, you should stop the therapy.
Okay. So, got it. All right. I'm looking at my next question. Here's someone who's asking, I'd like to know more about the long-term side effects of Flonase or Zyrtec on children.
So let's just go generally nasal steroids and antihistamines, right? So Zyrtec is a sedating antihistamine. Okay, so in about a third of the people. So there's a difference between feeling tired and actually having cognitive impairment. So that although you may take a medicine like Zyrtec and not necessarily feel tired, if someone to give you a Rubik's Cube before and afterwards, basically there'll be some differences in terms of your ability or time that you can solve that puzzle. So that's the cognitive impairment. So Zyrtec, again, is sedating. There are non-sedating antihistamines available for use in children. So I would not necessarily recommend that you should use a sedating antihistamine in any child. The long-term side effects, again, the dosing antihistamines on a daily basis really is of no benefit after about the first 7 to 10 days. So antihistamines should just be used on an as-needed basis. Nasal steroids, well, nasal steroids are really interesting. That basically, again, tolerance or, doesn't develop the use of medications. They're just as effective used on an as-needed basis as on a regular basis. So that although the label said these nasal steroids should be used daily, basically once you achieve symptom control, using the nasal steroid on an as-needed basis is just as effective. What people should be aware of that there's many of the nasal steroids contain benzalkonium chloride, which is BAC is the abbreviation, it's a preservative. And that can have some adverse effects on the lining of the nose and the eyes. And that basically many physicians out there worldwide believe that BAC should be completely banned from all nasal medications because of the potential side effects and adverse effect on the lining of the nose and eyes. This nasal stinging and burning that many people have from these nasal steroids is actually directly related to the benzalkonium chloride preservative. So there are some nasal steroids that have that. The problem is that the brand name nasal steroids like Rhinocort and Omniris are two brand name nasal steroids that don't have benzalkonium chloride. The generics though can choose whatever preservative they want, and it's unknown in terms of some of the generics. So if you get a generic brand of a medication, whether it actually may contain benzalkonium chloride as a preservative, because that may not necessarily be labeled that way. So it's kind of confusing. But the nasal steroids themselves, when used long-term, actually can show to cause actually healing of the nasal mucosa. So unless you're having direct side effects related to techniques such as nosebleeds from a nasal steroid, there's been no real long-term side effects shown, if you're using labeled doses or below the labeled doses of those medications.
So that's really interesting. So it's the BAC in that nasal steroid that really is causing the side effects that most people complain about.
Maybe causing some side effects, and is of particular concern. Okay, that benzalkonium chloride is an additive to when basically it's been shown itself that benzalkonium chloride can cause some damage to nasal mucosa.
Okay, so you also brought up the point of the generics. and I guess this works in any category, how do the lay people like me go and inform themselves about what the substitute ingredients might be, and kind of how do I make that choice? Because most people don't.
You really can't find that information generally. Specifically, it's hard for physicians to find that information. So that, we know that, basically these generics, although they have to meet certain formulation and certain biocompatibility testing, that they act differently in the body than the actual, branded drugs themselves. So that if you switch to a generic or switch medication and notice that there's a change in terms of your symptoms, you should talk with your physician in terms of whether it may be related to the actual medication switch. Pharmacists oftentimes mistakenly will, and I've heard this numerous times while walking through Costco, where the pharmacist is, arguing with somebody saying, no, the generics work just as well as the brand medicine. We know that's just not true.
Okay.
They do within certain limits, but certainly, the problem is in terms of, we don't know in terms of the other additives and side effects and other things that may have. And when we see loss of control in terms of symptom control, one of the first things you always question in terms of whether there's been actually a change in the product and the medication that the patient's taking.
Okay, so watch out for that, because those little switches, even though, we'll have the big drugstore brand as opposed to the pharma brand, we don't know what the actual, they say they're the same, just like whatever name of medication, but we don't really know because of those.
Yeah, we know that there's just very limited oversight of the production of generic medications by the FDA.
Okay, so buyer beware, I guess. And,
right.
Interesting. Okay. I feel like did we answer the question about kids though, specifically for kids?
So specifically for kids, I think, again, I would, as a general recommendation, saying, you need to really question about the use of any sedating medication in a child, a school-age person. And nasal steroids, again, there's just no data to show that the long-term use, in there's any adverse side effect per se. If you exceed label doses, and that's the problem. So majority of these medications are available over the counter, and it's just human nature that if you have a spray, I'll just do 4 sprays today. Hey, I don't see a problem. Then you can particularly run into problems, not just children, but adults too. So you need to take the label kind of seriously in terms of from a safety standpoint.
Okay, but their age and development factor is not one of the components to be afraid of.
It shouldn't be at the label doses. Yeah.
All right. A question about a natural remedy here. Every article I read mentions how nasal irrigation, aka the neti pot, can help with nasal symptoms. I hate doing it. Is it still worth doing?
I think, neti pots are interesting. So it depends upon how you make up the solution. So you can make a solution that's less concentrated than your normal tissues, which is a bad thing to do. That will lead to rebound nasal congestion. You can make up a solution that's the same concentration as the fluids in your tissues, which would basically have a flushing effect. Or you can make up a solution that's called hypertonic, a little more concentrated, which actually has an effect in terms of changes in terms of mediated release and protective effects, very similar to what nasal steroids do. So the other nice thing about nasal saline irrigations or hypertonic nasal saline irrigations is actually they help reestablish your normal anatomy, right? So if you have a mucus blanket on top of your nose, believe it or not, nasal steroids won't penetrate effectively through that. So one of the reasons that we see in terms of poor response to nasal steroid is the lack of delivery to the nasal mucosa. So doing a nasal saline irrigation beforehand, if you're just going to do just a normal concentration, will help flush off that mucus blanket, and allow better contact and penetration of nasal steroid. And nasal steroids get absorbed within a second when they're sprayed in. So it's not, if you sneeze 5 seconds later after using nasal steroid, you haven't sneezed the medication up.
All right. So translating in my English.
Yes, they work.
Yes.
Depends how you make it up, right?
Right, but I wanted to say it is beneficial to use to have a neti pot treatment.
Whatever type of system you're going to use. They're different. There's squeeze bottles or everything else. You can make up your own solutions at home, widely available on the internet in terms of making up these solutions. But yeah, they work very effectively. They're just they're cumbersome. If you may have liquid coming down your chest, the taste is not very palatable. Put a little xylitol in, helps in terms of doing some other things as improving the taste. But again, yeah, they work.
Okay, and may help the nasal sprays. All right.
Right, or they may reduce your need for the use of a nasal spray. Right.
All right. Okay. How important is it to follow dosage of any of these medications?
Well, I mean, it's kind of like driving a car. If the speed limit says, there's a curve coming up and you shouldn't go above 30 miles an hour, and you decide to ignore that and drive 100 miles an hour, you're probably exposing yourself to, certain dangers you shouldn't be. So the label on there, the label doses may not be the optimal dose for each person, but over a population of people studied, they basically said this is a dose which tends to be safe and also provides some effectiveness. So those label doses are on there because they basically tend to reflect more safety than benefit. So I would say take them, seriously. Your
Very
physician
good.
may prescribe different doses, and the physician is there to help determine, what's the optimal dose for use in an individual, not necessarily what's on the label, and then to discuss the potential side effects may be there if you're using doses other than the label dose, or even the label dose.
Okay. So I know that.
So buyer beware. If you're not going to follow the instructions, right?
Right.
If you're going to use a hair dryer in the bathtub, be careful.
Right. And I think that as consumers, we're very tempted to think that a little bit more is a little bit better, but don't do that with medication.
Especially when things are over the counter. The people tend to say, it's over the counter. It's got to be really safe. It wouldn't be over the counter, would it? Right. Okay.
Right.
Even Benadryl are on for years. We know that it can cause irregular heart rhythms and other things as well. They're not necessarily entirely safe per se.
All right. So new slogan. OTC does not equal safe necessarily when used off-label or not within the dosage recommended. Yeah? Okay. Here's an interesting one. Do antihistamines also work for food allergies related to pollen? So like cherries or sunflower seeds. Some people are saying that these specific food might cause nasal allergy, like nasal symptoms. So
none of the medications are specific to what's triggering the allergy. They work on basically once the allergy has been triggered. So they work on medication, the chemicals are released once the allergy has been triggered in your body. They don't discriminate whether it's a food cause or an animal cause or your mother-in-law or your sister-in-law or pollen, basically. So it's not specific to the trigger. It's basically treatment of the symptoms associated with an allergy. Does that make sense?
Not.
So basically, antihistamines are antihistamines. They block histamine, regardless the receptor, regardless of what's caused it to be released, whether it's a food, a pollen, other things as well. So the antihistamines, that's how they don't work against the allergen itself, the trigger.
Okay. Got it. So if I love cherries, but I also have allergies, my antihistamine that works for me would also work when I'm eating cherries, not to worsen my symptoms. Is that correct?
Go ahead.
I think what the doctor's saying is they don't treat the root cause of the problem. They just treat the symptom.
Yes.
Or, the symptom of it. So that's what's important here is like there's these medications, they treat the symptoms and maybe not the root cause.
Yes.
You're hired. Yes. Exactly.
Yes. But so as a person who is absolutely manic about cherries, I will not get more symptoms because I've already taken my antihistamine in the morning. No, doesn't work that way. Okay.
So there are other chemicals that are released besides histamine in the allergic reaction. Antihistamines only work against that single chemical. So that doesn't mean that you won't have other symptoms. So, I mean, it gets really, as you can see, it can kind of get really a lot more complex. And that's why I sit down with your doctor and talk about specifically, what are the triggers, what can be done to avoid the triggers, and if nothing can be done to avoidance, what can be done to treat symptoms that have the fewest side effects for you.
Okay.
Yeah.
All right. No cherries for Anne-Marie. All right. Here's a broad question. Let's see if we can answer this. I don't know if it's, let's see. What do you do when no medication seems to make a dent to relieve your symptoms?
So as a specialist, I oftentimes see people who are treated with multiple medications and multiple types of treatments, and they're not any better. They come to see me. You need to, first of all, question the diagnosis at that point, because we know that certain medications do have benefit in treating allergies. And if someone isn't responding appropriately, the first thing to do is to question the diagnosis. Are these, not every headache is from a brain tumor. So if somebody comes to you with a headache and you take their brain out and their headache goes away, you say, oh, so you had a brain tumor. So if someone goes to a doctor and they're saying, gee, I have allergies, and they give an allergy medicine, their symptoms get better, it doesn't prove that they have an allergy. So then when those people go to the doctor and they're treated with multiple medications and they don't get any better, the first question is this person's symptoms actually from an allergy, or is it from another cause that mimics an allergy? And so I think that's probably the most important. I think 9 times out of 10, people are misdiagnosed with allergies, put on allergy medications, and they don't respond to the treatment because they don't have that disease mechanism causing their symptoms.
Okay. So see your specialist.
Well, see somebody.
All right. Next one. What is your opinion or tackling? Okay, this is what is your opinion about tackling some allergies with saline sprays or neti pot versus fluticasone purport? You say it, Dr. Lisberg. So I think we might have answered that a little bit.
So what's the question? I was kind of.
What is your opinion about tackling some allergies with saline spray, aka neti pot, versus fluticasone?
So the bottom line is that we have therapies that treat symptoms. So the idea is to get on the optimal therapy that gives you the best symptom relief. If it's using just an hypertonic nasal, saline rinse, and that gives you adequate symptom relief, you don't need to add another therapy. If you're using, a nasal steroid and have inadequate relief, the addition of a nasal saline spray may provide some benefit. It may not. So that I think the idea is that, we focus on symptom relief. We don't have, as Maria said, we don't have any treatment for the underlying root cause. So it's a matter of treating this, whatever gives you best symptom relief.
And whether you prefer medical, and whether you prefer natural over.
I'm not sure it's so natural sucking salt water through your nose, but it's that, I mean, arsenic is natural. I wouldn't recommend arsenic to people. So the natural therapies out there. The idea is in terms of we know the nasal saline sprays, not just the mist sprays, but you have to use a certain volume each time you do it. Provides benefit. We know that nasal steroids provide benefit. We know that the combination of the two, may be better than using one alone for individuals. It's all based upon the individual symptom and their response.
Thank you. Here's a question about trends in your office. What have you seen in your practice regarding older people experiencing symptoms of allergic rhinitis for the first time in their life?
So, okay, yeah.
And should they be careful about the use of medication? So I'm thinking there's contraindication
So we'll go to the second thing, right. If people haven't figured out by now, everyone needs to be concerned and understand about side effects. You dose medications based on the side effect. We know that if it's approved medication, they work. The question is what's going to be safe in the dosing for each individual. So that's what you monitor. Older people, you don't see older people on Benadryl commercials or Claritin commercials or Allegra commercials or Flonase commercials. And there's a reason that basically, allergies or seasonal allergies tend to be a disease that had the onset in childhood or early adulthood. And then basically, most people, the symptoms tend to disappear over decades. So if someone walks into your office and they're 60 years old and they go, gee, I've lived here my entire life and this is my first time ever having a seasonal allergy, say, look, you have a symptom of a seasonal allergy, but it's going to be highly unlikely that all of a sudden at age 60 they have the first onset of pollen allergies. It just doesn't occur.
So see your doctor to see what it
So I would think of
is.
see your doctor and think about an alternative diagnosis.
Mm-hmm.
Right.
All right, interesting. Let's see. Is sinus pain and hay fever migraines all linked to inflammation from allergic rhinitis?
Wow, what a big general question. So migraine, so here's the thing, people with allergies can have sinus pressure, dullness, but allergies do not cause headaches. So the people who have a sinus migraine or sinus component or headaches associated with nasal symptoms, that's typically unrelated to allergies, but related to what's called the neurogenic rhinitis or migraine syndrome. There used to be a neurologist next door to me. I would joke to him and say, gee, what do you do for sinus migraines? He goes, you mean migraines? I go, no, sinus migraines. He goes, you mean migraines? I go, yeah. I go, basically people come to you for the headache component, but they come to you for the sinus congestion. He goes, oh yeah, they all have that. I go, but you don't treat it. He goes, well, that's not the migraines. Migraines are a headache syndrome. I go, no, migraines are a nasal sinus congestion syndrome associated with sleep disruption and other things. And yes, on one end of the spectrum, there are people who have frequent headaches. The spectrum that I see are people come to you on allergy medications for years and treatment for years for their nasal congestion and sinus problems, which actually are a form of a migraine syndrome, and they respond rapidly and immediately to migraine treatment. So I think, it's this kind of like spectrum of disease where there's this, what we call a vasomotor component, where the neuro blood vessel component, and that allergies can trigger that type of component, leading to congestion. But for people with a migraine syndrome, they have all these other things. But one interesting thing is that people with a migraine syndrome rarely have ever had itching as a symptom. And itching is a symptom that's caused by histamine release primarily. So that if people get, gee, I get sneezing, I get congestion, all this stuff by nose and eyes, rarely itch, it's unlikely that there's an allergy trigger component for their sinus condition. They need to think of other alternative diagnoses.
Are you saying that itching is a separate symptom to look for?
So here's the thing, in medicine, doctors always treat that. Take a medical history and ask all these questions, and they say, do you have this, do you have this, do you have this? The most important question you can ask someone when taking an allergy history is, do you not itch? Not do you, okay? So the absence of itching correlates highly with the absence of a relevant allergy mechanism. Now, if you do have itching, about 20 to 30% of people that have itching as a symptom still don't have an allergy symptom. But everyone who has an allergy trigger for nose and eye symptoms has itching associated with it at some point. So people come in, and I typically would see the people who are on multiple allergy medications on allergy shots, and come in and go, gee, and they come and go, gee, I feel lousy, I'm congested, I'm sneezing all this time, blah, blah, blah. And they go, gee, your eyes, nose, mouth, and throat itch. And they go, and they have to think about it. As opposed to some who have allergies, you ask them, gee, your eyes, and they stop, you go, oh yeah, my eyes itch or my nose itches. They stop you right away. Okay, because that's a prominent symptom that occurs to the allergy. The absence of itching. So looking for a negative signal is really important in terms of taking an allergy history.
Oh, well, I did not know that. Thank you. I think that's really fascinating.
90% of the medical community don't know.
Okay, so not just me as a layperson, but even the
you as a
medical.
doctor.
Wow. Okay, that's really love hearing that. Okay, another question: do I need to get allergy tested every year? How often should one get tested?
So allergy tests just tell you have an antibody in your system. So about 40 to 50% of the population, if you just drag people off the street and allergy test them, will have a positive allergy test or something. But we know only about a quarter of those people actually have a disease. So an allergy test itself just tells you the presence or absence of an antibody there. It doesn't tell you if you have a clinical disease. Those people who have an established diagnosis that that antibody is causing something, we call them allergic. Okay, and once you're properly tested and the tests are recorded in a fashion that's reproducible and outside of the doctor's office, you don't need ever to be retested, because allergy test responses don't really change at all with therapy, whether it's allergy shot therapy or medication. A positive test stays a positive test. The size of a positive test doesn't really mean much once it's positive. So people with a small positive test may have huge symptoms. Someone with a large positive test may have few symptoms. Okay, we do it in terms of establishing a diagnosis. Once the diagnosis is made, you should not have routine or regular testing every year or every few years to find out how your allergies are doing. Allergy testing does not correlate with clinical symptoms.
Wow. Okay. Another great takeaway. Thank you. So we are at time. I wanted to see if anyone had any other questions. If so, please use the raise your hand icon at the bottom. If there's any follow-up questions or any clarifications you wanted to ask Dr. Lisberg, please go ahead and we can take your question quick before we wrap up. Anyone? Marina, let me know if you're, oh, Lawrence has a question. Yes, Lawrence. Whoop, we need to unmute him.
You need to unmute yourself.
I just wanted to mention that Ed Lisberg was awesome.
Ed Lisberg was awesome.
Yeah,
I agree.
That's all I want to say. That was great. I learned so much today. Thank you so much.
That's only because I feed you. Yes. Okay.
Okay. Anyone else?
Susan had a question. Yeah.
Susan, do you want to unmute yourself? Is Susan still there? Oh, there she is. Causes of postnasal drip.
So other than other than allergies, right? Other than having a cold, okay, one of the more common causes out there in the community is actually acid reflux.
Mm-hmm.
So that people, when they have acute reflux symptoms, get heartburn, but people with chronic acid reflux don't have heartburn. They have throat clearing as a common symptom because when the acid comes up, it causes a nerve pathway trigger to your upper airway to get swollen and produce mucus. So that's one of the common things I would see people come to me for allergies when they actually had chronic reflux because they came with this chronic postnasal drip. Other things, other diseases, underactive thyroid. So I probably see half a dozen people a year who had hypothyroidism, which present as nasal congestion and postnasal drip. Those are probably the most common things we see. So basically allergies, the non-allergic, rhinitis syndromes as well in terms of the people who are sensitive to temperature changes, weather changes, migraine syndrome, acid reflux, and hypothyroidism. Yeah, most of them can come right there. And of course, we always have to mention pregnancy.
What else about pregnancy?
I'm not an obstetrician, so I can't tell you anything about pregnancy.
Okay, you brought it up, so I thought I would.
Yeah, no.
I would ask.
Other than it can be associated with nasal congestion and postnasal drip. Yeah.
Okay, all right, very good. Anyone else? Last chance before we sign off? No? Well, I thank you. This was awesome. I'm sorry if I misinterpreted any of your conclusions, Dr. Lisberg, but I'm trying to absorb all of this new information, stuff we've never heard before. So I certainly got some great takeaways. Thank you. And enormous thank you for your time. And, if you do have any follow-up questions, you see the slide right there. These are all the places where you can reach us. And we would especially like to know what you would like to discuss next, and if you found this helpful at all. So that's it for today. Thank you again.